Uh, Good morning, everyone. So first of all, I would like to thank IIP Aurangabad and organizing team for wonderful this regional conference and giving me the opportunity to be here. So before wasting much time, I will proceed. So before I start my talk, I would like to acknowledge all my teachers, colleagues, and my friends because of whom today I am here. So this is not the just a case discussions, but we will discuss some scenarios. So this is the first scenario that 4 kids with the same scenario. So short stature and anemia. So let's see case by case. So this is the first case, common complaint of all 4, not gaining weight and a height. In first case, 6.5-year-old male child coming with sluggishness, decreased activity, decreased intake and easy fatigability. Second child, 7-year female, consanguineous marriage and elder sibling death in family. Third case, 8-year male, repeated infection, failure to thrive, history of blood transfusions and pallor. And case 4, 6-year-old male child, not able to flex the finger, pallor and weakness. Now see, almost age group is same, presenting complaints are same, but let's see what is the conclusion. So on examination in the first child, only short stature, anemia, no organomegaly. Second child, pallor, short stature, polydactyly, high arched palate and no organomegaly. So dysmorphic features are there. Third case, short stature, pallor but hypopigmented skin and hair, and on investigations there were cytopenias. And in case 4, along with this short stature, stubby fingers, large head, coarse facies, coarse hair, inguinal hernia, organomegaly, and skin papule and few lipomas. So in first case, let's see the investigations. You can see clear-cut anemia with hemoglobin of 3.5 and which is microcytic hypochromic anemia with increased RDW. So the picture is like IDA, iron deficiency anemia. The rest of anemia workup is normal. So is this a simple nutritional IDA? I would say no, because the first and foremost clue is unusual age for the IDA. So the 6 and 7 years is not the age, common age for the IDA. Along with that short stature, and on history we got a clue that there was an intolerance to the wheat-based diet. So this child we suspected of celiac disease, tissue transglutaminase was 194, gliadin antibodies were 72 and anti-endomysial antibodies was positive 1:10. So clearly this was a case of celiac disease. We started with gluten-free diet, which is the mainstay of treatment, iron multivitamin supplementation, deworming and monitoring of growth. And this child is really doing well. In 1 year, he gained almost 4 centimeters of the height. Now the first and foremost clue, like when we say that let's give gluten-free diet, so no wheat, give jwari, give bajri, give nachni, anything. बट वो पिसना कहाँ से है, कुठून पिसणार? जर त्याच गिरणीवरून जिथे पहिले गहू दळलेले आहेत, so patient is not going to recover well. So as a doctor, when it comes is a counseling, so not only to change the atta, but change the chakki also. So that is very important. Second case, child with a dysmorphic feature, short stature, anemia, clear cut, it is pancytopenia with ANC of 800, hemoglobin 6.5, platelet 76. USG was showing horseshoe kidney, bone marrow, hypoplastic anemia. Stressed cytogenetics were positive for Fanconi's anemia and her Fanc gene A was positive. So this was a case of Fanconi's anemia, and this child, we have kept her on the treatment. Then the case 3, this is the short stature anemia with hypopigmented skin, hair, multiple blood transfusions, cytopenias, repeated infections. Now this child, we thought hepatosplenomegaly was also there. So we sent his NGS and it came positive for Hermansky-Pudlak syndrome. So this is the anemia with short stature with pigmented dilutional disorder. Now this is the 4th case with coarse facies, short stature anemia. Now his urinary gag was positive because this was not routinely presenting into the routine anemic cases. So thought something out of box. urinary glycosaminoglycans was positive. This is what his workup. He is positive for Hunter's syndrome, that is IDS, gene was positive. So, friends, when things do not fall in specific equation, let's think out of the box. Now, when we discuss anemia, presentation cannot be complete with discussing without discussing CBC. So, same age, same sex, everything is nullified, and these are the two CBCs. So, simple thing, a simple approach to the CBC when we read, we need to look not only at HB, but also the MCV and RDW and the RBC parameters. So when we have a low MCV and normal RBW, this is thalassemia trait, very important. Low MCV and high RDW, it is IDA, and low MCV and very high RDW, when RDW is in above 30, 32, it is thalassemia major. So it's simple clue, when your RDW is high, it's a nutritional anemia, and when your RDW is normal or very high, it is non-nutritional anemia. So simple clue. So these are the two CBC. In the first CBC, low RBC count, low MCV and high RDW. So this is iron deficiency anemia. Then another CBC, when we have a high RBC count, low MCV and normal RDW, this is thalassemia trait. So as a pediatrician, it's our responsibility not to miss thalassemia trait when you see every CBC. So low hemoglobin, low MCV, normal or high RBC count and normal RDW. It should be thalassemia trait, should be confirmed with HB electrophoresis. Second scenario, when we have a hypopigmented skin and hair. One we have seen Hermansky-Pudlak. So now this is the 4-month male, came with infections, started from day 15, organomegaly, secondary HLH, hypopigmentation. And this is the second child, 2-year female. She presented with convulsion and ataxia, HLH and hypopigmentation. So in case 1, this was the peripheral smear, and we showed the granulation in the neutrophils as well as on the bone marrow. So this is nothing but Chediak-Higashi syndrome. And in case 2, when we saw the hair shaft, this is hypopigmented hair shaft. Her NGS workup was positive for RAP27A gene, so it is a Griscelli syndrome. So it is simple. It is when you have a hypopigmented skin and hair with anemia, short stature, HLH-like phenomena. Simple test, peripheral smear, when you see multiple giant granules in PMN, that is polymorphonuclear cells, it's Chediak-Higashi. When you see hair shaft, no granules in PS, hair shaft is hypopigmented, it's Griscelli syndrome. And along with all clinical manifestation, if child is having mental retardation or bleeding tendency, you can suspect Hermansky-Pudlak. The third scenario, anemia with hepatosplenomegaly. Now this is the case, 4-month male, not gaining weight, increased irritability, delayed cord fall and developmental delay. On examination, you can see severe failure to thrive, pallor, squint, nystagmus, signs of recast, organomegaly and absent neonatal reflexes. This was the investigations which was showing anemia, but strikingly there is a polymorphonuclear leukocytosis and thrombocytopenia. The rest everything was okay, but on PS there were 88 NR, that is nucleated RBCs per 100 WBCs. This was the radiograph which was showing increased bone density, clubbing of metaphyses. So clear cut, it is osteopetrosis. Now ophthalmic workup, nystagmus and was there, and Vera sensory neural hearing loss was there. We did LAD workup because consistently, in spite of CRP is normal, but leukocytes count were going higher, high on high. So just taken a chance and LAD workup was positive. The mean fluorescence intensity of 99% of neutrophils were low and LAD1 was diagnosed. So friends, what is it? Is it like 2 different entities in one patient, or is it something one which is causing 2? So this is very important, and here it is the role of NGS. So the culprit is kindlin 3 gene. So this is the kindlin 3 gene which is responsible for integrin activation, osteoclast resorptions, blood clot formation and leukocyte form addition. And when you have absence of kindlin 3, we get 3 things: bleeding disorder, immunodeficiency, and osteopetrosis. Second scenario, anemia with hepatosplenomegaly. This is 10-year male, came with failure to thrive, repeated severe infections, abscesses, anemia, hepatosplenomegaly, lymphadenopathy. This child developed literally sinuses, discharging pus discharge from multiple lymph nodes. Every time new organism was coming positive, no final diagnosis. So finally we sent NGS, and it turned out to be MSMD, that is Mendelian susceptibility to mycobacterial diseases. This child is doing well. He found to have interleukin 12 receptor beta 1 gene defect. So it is very important to think not all hepatosplenomegaly and anemia need not to be always thalassemia, sickle cell or malignancy. So when you don't get these answers, let's think something different. So case 3, again, a respiratory complaints in 8-year-old child, cough, fever, breathing difficulty. He received antibiotics, pleural tap done twice. On examination, there was distress. Organomegaly, air entry was decreased on right side. This was his X-ray. So let's identify this emergency. It is not just a simple pleural effusion, but this is a large mediastinal mass with respiratory distress. So no need to hurry up in investigations. Stabilization is most important. Don't put patient in supine position. First counsel the patient, make him relax, make him comfortable, and put IV in lower extremity. That is very much important. So this was the CBC which was showing TLC was 1 lakh. PS was full of blast. This is clear-cut case of leukemia. And the TL profile was suggestive of tumor lysis syndrome in terms of hyperkalemia, hypocalcemia, hyperphosphatemia, and hyperuricemia. So this was a hyperleukocytosis with TLS. So we admitted in PICU. Hydration should be started with plain DNS, no potassium to be added. This is just, you all know all these things, but it is just a revision. Monitor CBC and TL profile every 4 to 6 hours. If patient is bleeding, give platelet transfusion. Avoid PCV transfusion in case of hyperleukocytosis. Allopurinol and Gelusil should be started for the TL. Monitor urine output, which should be more than 1 ml per kg per hour, and no anesthesia to be done for any procedure. Remember, though this is leukemia, bone marrow is not important. Even you can do a pleural tap, send pleural fluid for flow cytometry, you can get the diagnosis. And early referral with accompanying person is very important. So this is a clinical approach to anemia. So when you get a patient with anemia, without lymphadenopathy, without hepatosplenomegaly, no petechiperpuria, it can be nutritional anemia or PRCA, that is pure red cell, thalassemia trait, lead poisoning, or anemia of chronic disease. When you have anemia with petechiperpuria, there is a aplastic anemia, bleeding disorders. When anemia with hepatosplenomegaly, no bleeding, thalassemia, hemoglobinopathy, or liver disorder. And when you have anemia with all 3 cell lines involved, it can be a malignancy. So the third last scenario, can I have 2 minutes or should I stop? Yeah. So the last scenario is rash. So we have 4 kids. The case 1 is 3-year only with petechi, active playful child. Case 2 is 14-year female with knee chymosis, no other complaints. Case 3 is 6-year female with rash, irritability, periorbital puffiness, and past history of hospitalization for the fracture femur. And case 4, it is 15-year male with abdominal pain, swelling over wrist, knee, rash over gluteal region, and now patient is having hematochezia. So on examination, the first child is active playful with petechial rash, second child is with knee chymosis, active, stable. Third child and fourth child both are sick looking. The third child is sick looking, ecchymosis, periorbital puffiness, no organomegaly. And case 4 is sick looking, petechial rash, and empty right lower quadrant. So these are the 4 cases. So the case 1, platelet is 10,000, rest everything is normal. PS is showing no abnormal cells. Bone marrow is showing starry sky appearance in form of multiple, you may not be able to appreciate, but multiple megakaryocytes. So this is a clear case of ITP. The second case, platelet is 5,000, and this is the peripheral smear, and you can see these are the large granular platelets. The third case is the normal CBC except from the anemia, but there are multiple fractures, and the The old fractures are also there. And the case 4, normal CBC with X-ray abdomen showing empty right quadrant and there are no gas shadows. So in case 1, as I said, this is the clear case of ITP, no significant history, active playful child, typical age. Case 2, again large granular platelet, female child, mother was having menorrhagia history, and this is GP1B defect, that is Bernard-Sollier syndrome. The case 3, this is the clear case of child abuse. Remember, when there is problem, it should not be necessary that pathology should be in blood reports. Pathology can be in family. So we need to suspect very early, inform to the police, counseling of the parents, and prompt treatment of children is important. And the case 4, it was an adolescent child with rash, connective tissue disorders like knee joint swelling, wrist swelling, and now the complication is the intersusception of Hinosh-Schollin purpura. So not all rash is thrombocytopenia. So finally, last slide, history and good history is very important, along with the complete examination. Send investigations very wisely, avoid sampling error, get tests done in standardized lab, interpret test in relation to clinical condition, repeat if abnormal. Not all thrombocytopenias are always ITP, not all arthritis are always JRA, not a normal CBC does not rule out hematological or immunological disorder. And in emergency, always treat child first, investigations can wait. Thank you so much for patient listening.
Thank you very much, ma'am, for sharing your profound knowledge with us.